So I'm just covering the basics of biometry, particularly the tips and the traps that we can get, take advantage of. So in this era where cataract surgery means a refractive outcome for the patient, it is very important for a cataract surgeon to be well versed with the nuances of biometry and to use that data to determine the ideal intraocular lens power. So first and foremost, we need to identify what is the goal. Is it emetropia? Because sometimes we may not actually be choosing emetropia based on the patient's requirement and the other eye status. So it's very important to take accurate measurements, collect that data, use the appropriate IOL formula, particularly the newer generation formula, and as Vinita has covered, optimize for the best result. It's important that when we are considering intraocular power calculation, we should not, be handling the cornea. So we should, for instance, not do an applanation or a gonioscopy that day. You're going to change the readings. Always have a trained optometrist or do it yourself and be well versed with the technique, with the machine, with the data entry. Be very careful that you are entering all the data appropriately, and your optometrist should be able to pick out anything which is a red flag, and always take multiple readings. Always measure both the eyes. Make sure that your instruments are calibrated regularly and look out for the unexpected. So for instance, if you have an asymmetry in the two eyes or you have extreme values, you must repeat and double check these readings. So if you have an axial length of less than 22 or greater than 25 millimeters, a keratometry which is too flat, less than 40, or too steep, more than 47, a difference in the two eyes of axial length more than 0.3 millimeter, or a keratometry of greater than 1 diopter, an astigmatism which is over 1.5 diopters, a difference in the IOL power calculation of more than 1 in the two eyes, then always repeat and confirm your readings. So what are the basic components? By and large, we used to consider the keratometry and the axial length in the two variable formulas. But now there are multiple measurements that are there: the white to white, AC depth, lens thickness, refraction, and the age. Why so? Because like Dr. Shalini had covered, we have to calculate the predictive or the effective lens position, and that does not always follow a rule that shorter eyes would have a shallow AC depth or a longer eye would have a deeper AC depth. And therefore, multiple variables addition is making the IOL power calculation more fine-tuned. So keratometry is mainly measuring the corneal power, and we measure the anterior corneal curvature here. We are assuming the corneal refractive index to be 1.3375. And this keratometry is it's not causing a lot of error when we are talking about the IOL power calculation in eyes that are going for a monofocal IOL. But in case there is a toric power, then the keratometry becomes very, very important, because then the inaccuracy can lead to an error of in as many as 27% of patients. So in case, see, when you are doing keratometry, it's very important that the eye should be well lubricated. The cornea, the positioning should be central. And the person should be off contact lenses if they are usually using contact lenses. Make sure there's no scarring and calibrate your instrument very, very well. Approximately an error of 1 diopter in keratometry leads to a 0.8 to 1 diopter error in the IOL power calculation. So both the manual K and the optical K do well, particularly if it's done by someone who's trained and the instrument is well calibrated. But the optical K is now integrated with the IOL master and all these machines, so it is fast, reliable, and quick. So oftentimes we are going for the optical K now. The axial length is the most important parameter for an accurate IOL power calculation, and it is also the most common source of errors. And a small error can lead to a much larger effect in the refractive outcome. So it's very important to focus on the axial length measurement and to make sure that you are taking the optical and not the anatomical axial length. So this is the reason that nowadays we are going more for the optical equipment like the IOL Master, because it's going to measure the true optical axis. So the true optical axis would be to the macula and not the actual anatomical axis. In case we are using the ultrasound, then we prefer to use the immersion, because the chances of compression of the cornea and falsely having a lower axial length become lesser. And make sure again that the instruments are well calibrated, and in case you are doing the immersion, then you make sure that you get good spikes, you adjust the gain. And if you do it along with the B scan, you are able to make sure that you are taking it in the optical axis. Preferably, we take the biometry measurements before we dilate the pupil. Yes, so this is the accuracy that we see. Of course, when we are doing the optical biometers, the accuracy is much more as compared to the contact or the immersion A scan. Choose the appropriate IOL formula. By and large, in the normal range of axial length, most of the formula work well. Nowadays, the Barrett Universal 2 is being commonly used, as it covers a lot of eyes, even hyperopic, myopic, post-refractive. So, like ma'am has already covered, for the extraordinary situations, which powers to be used. Yeah, so I hope that it's clear and your patients are able to, be very happy with the refractive outcomes. Thank you so much.